Hello, my name is Steve Ciciora. I'm a pediatric gastroenterologist in Columbus, Ohio, and today I'd like to talk about hepatitis C, specifically vertical transmission to the neonate, testing, and new therapies for hepatitis C in the pediatric population. So before we get started, I'd like to review the objectives. I want to review the risk of vertical transmission of hepatitis C. And after this, you should be able to know how and when to test for hepatitis C in at-risk newborns. And finally, we'll briefly review pediatric treatment of hepatitis C. Before we get into the talk, I think a clinical scenario would be helpful. And this clinical scenario is actually something that I see personally quite often, and I think it'll be helpful to frame our discussion about vertical acquisition of hepatitis C. So we're seeing a 2-month-old child for a well visit. The child is brought to the visit by the foster mother. The biological mother lost custody of the child due to IV drug use, and the biologic mother is known to have hepatitis C. The mother tested negative for HIV and hepatitis B, however. The infant is at the 50th percentile for all growth parameters and has an unremarkable physical exam without jaundice, icterus, or hepatosplenomegaly. The infant is fed a cow's milk-based formula without difficulty in stools, yellow, green, seedy stools 2 to 4 times per day. So it sounds like a pretty healthy 2-month-old. The foster mother wants to know whether the infant has hepatitis C, and if so, what should be done about it, as she knows there are new treatments currently available. So let's review hepatitis C a little bit first. Hepatitis C is a single-stranded, enveloped, positive sense RNA virus. And in terms of who gets hepatitis C, far and away, the #1 cause of getting hepatitis C is intravenous drug use. It's been estimated that up to 50% of IV drug users may have hepatitis C in the United States. Most infections in the United States are of genotype 1. There are numerous numerical genotypes of hepatitis C, with the most common being genotype 1. And it's estimated that there's 45,000 new cases per year, with an estimated total of about 2.4 million Americans in the United States with hepatitis C. One thing that was a problem in years past, but is no longer a problem, is acquiring hepatitis C through blood transfusion. It's now exceedingly rare since 1992, since the donor blood pool has been screened for hepatitis C routinely. It's estimated to only be a 1 in 2 million chance of one would receive a blood transfusion today. Likewise, acquiring hepatitis C through sexual intercourse is not common. It does happen, but again, far and away, the most common route of one getting hepatitis C is through intravenous drug use. It's estimated that 5 million children worldwide have hepatitis C, and that there's 150,000 kids in the US under 18 years of age who have hepatitis C. Now, the focus of this talk is on vertical transmission. That refers to a mother giving her infant hepatitis C. The thing is, we don't really know when exactly vertical transmission occurs. It can occur, the definition encapsulates all that transmission that occurs during gestation, at birth, or in the first 28 days of life. Like I said, it's not exactly clear when the infection occurs, though it's thought to be late in gestation that it happens. Now, in a mother with hepatitis C, the likelihood of her transmitting it to her newborn is around 5%. That's a key figure to remember. And it's about double that, 8 to 10%, if the mom is co-infected with HIV as well. In 2014, it was estimated that 3.4 per 1,000 births had transmission of, or had a mother, who had hepatitis C, and that number has only surely increased since 2014, with increasing incidence of hepatitis C in the general population. Certainly, we know that the maternal hepatitis C viral load plays a role in transmission, with higher viral loads in the mom being more likely to lead to virus transmission to the neonate. Chorionic villus sampling and fetal scalp electrode monitoring have also been associated with an increased risk and increased likelihood of that newborn being born with hepatitis C. However, interestingly, the mode of delivery, C-section versus a vaginal delivery, does not seem to play a role in the transmission of hepatitis C from the mother to the newborn. Now, we said that the transmission rate is around 5%, but even in those infants who get hepatitis C via vertical transmission, in the first 4 years of life, 25 to 50% of them actually clear the virus by the time that they're 4 years of age. So getting the virus vertically, there's actually a very, very small chance of that, about 5%. And even in that 5% who do in fact test positive, they have about a 25 to 50% chance of clearing the virus in their first 4 years of life. Now, in terms of testing, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, their most recent guidelines, unfortunately, go all the way back to 2012. They say that the diagnostic test of choice is the hepatitis C antibody test, and that should be done after 18 months of age. And that's because if one were to test for an antibody test before 18 months of age, there's a possibility that the test could be falsely positive and actually be mom's hepatitis C antibody that was passed transplacentally. Thus, the hepatitis C antibody test is not recommended in the first year and a half of life. They also state that you can do PCR testing as early as 2 months of age if there's a family desire to sort out if the child has hepatitis C, or there's other social situations that would merit ordering that test. More recently, however, I would recommend, if there's any question as to testing and therapeutic choices, that one refer to the combined IDSA and AASLD recommendations that are updated routinely. The recommendations that you see on the screen now are actually from December of 2019. They specifically say that all children born to hepatitis C infected women should be tested for hepatitis C infection. They also recommend to use an antibody test after 18 months of age, and that an RNA test, hepatitis C virus RNA test, can be done in the first year of life, but the optimal timing of that isn't really known. And that you can do a hepatitis C RNA test as early as 2 months of age. Between 0 and 2 months of age, they really don't recommend any testing, but after that, one could do an RNA level. They don't recommend repeat testing prior to 8 months of age, and that they also recommend that any child who is antibody positive, that test should be followed up with a RNA PCR to confirm diagnosis. And likewise, if you're seeing one child, you should ask yourself if there's any siblings, and those siblings should be tested as well. Now, if one were to confirm a diagnosis of hepatitis C in an infant or toddler, there's a series of recommendations about how to monitor that child. The first two, I think, are the most important. They recommend annual labs with AST, ALT, bilirubin, and protein levels, and they recommend that to assess for disease progression. Hepatitis C is a very slow and indolent virus, so in the vast majority of cases, children are totally fine, but this monitoring allows you to pick up the rare case of a child with a more, for whatever reason, a more aggressive case of vertically acquired hepatitis C. Most important, however, is that the child who has hepatitis C make sure that they are also getting their vaccines against hepatitis B and hepatitis A, so as to protect their liver from other viral hepatitis infections, which are fortunately preventable. You can see there's some other recommendations as well for you to review. Now, if one were to confirm that a child has vertically acquired hepatitis C, I'd say 5 years ago, the treatment really wasn't that good. The mainstays of treatment of both adult and pediatric hepatitis C weren't very tolerable. Patients received injectable interferon weekly, and oftentimes ribavirin orally as well. The sustained viral response to this therapy, SVR stands for sustained viral response, which refers to the fact that there's no virus detected 6 months after the end of therapy, was anywhere from 40 to 100%. Now you have to remember that this therapy required once a day to twice a day dosing of ribavirin, and then weekly injections of pegylated interferon. Interferon, if you recall from med school pharmacology, is not very well tolerated. It leads to fatigue, myalgias, headaches, and we were asking patients to give themselves or have their parents give the child injections of interferon weekly for up to a year. So one of the main problems with this older therapy was tolerance and then therefore adherence. The SVRs, you can see that there's quite a wide range between 40 and 100%. The outcomes were actually not very good in genotype 1 hepatitis C, which, as I mentioned before, was the most common. Other genotypes were more susceptible to the interferon and ribavirin combination, but less so hepatitis C genotype 1. Fortunately, kids are unlikely to develop complications of hepatitis C. Like I said, it's a slow and indolent virus. So for the kids who recently got hepatitis C, we've been telling them to wait for newer therapies. So the newer therapies that many of you may have heard of are called the direct-acting antivirals, or DAAs. These target specific proteins, proteases, or polymerases that are key to hepatitis C replication, and they're used in combination therapy, very similar to how HIV drugs are used now. The AASLD came out with a statement that states, direct-acting antiviral treatment with an approved regimen is recommended for all children and adolescents with hepatitis C virus infection age greater than or equal to 3 years, as they will benefit from an antiviral therapy regardless of disease therapy. So this is a very notable statement in saying that all children greater than 3 years of age should be treated. Now, the direct-acting antivirals, there's a whole host of those regimens that are approved in adults. At the time I made this talk, the two combination therapies available for kids are ledipasvir and sofosbuvir, as well as sofosbuvir and ribavirin. And these are actually approved down to 3 years of age. And the choice that one makes depends on the genotype of hepatitis C that the child has. The one drawback to these therapies, although they're very, very effective and all oral, there's no injections that are needed, they are very, very expensive. And that's been a key holdup into getting more people, both children and adults, treated for their hepatitis C. So we'll return to our clinical scenario for a minute. So remember the 2-month-old child that you're seeing for the well visit, who's brought in by the foster mom. Foster mom wants to know whether the infant has hepatitis C, and if so, what should be done, as she knows there are new therapies. So since the child is 2 months of age, and in this social situation where the child is in foster care, I personally think it'd be important to know whether or not this child has hepatitis C. So I would order a hepatitis C PCR. If it was positive, indicating that the child vertically acquired hepatitis C, I would keep in mind that there's still a chance, about a 25 to 50% chance, that prior to this child reaching the age at which therapy is approved, that's around 3 years of age, they could in fact still spontaneously clear the virus. So if positive, I would monitor the child at least annually with metabolic profiles and physical exams. And then again, I'd keep in mind the chance, and I'd tell the foster mother as well, that spontaneous clearance is possible. However, given the numbers that we reviewed earlier, the likelihood of this child actually having hepatitis C are pretty small, a 5% chance approximately of having vertical acquisition of hepatitis C, and therefore a 95% chance of not vertically acquiring hepatitis C. I'd also make sure that the pediatrician is completing the child's hepatitis A and B immunizations routinely as well. So take-home points for this, the risk of vertical transmission is low. It's about 5%, but around 8 to 10% if mom also has HIV as well. Remember that spontaneous clearing can occur in infancy and toddlerhood, and that we need to avoid antibody testing in the first 18 months of life because that antibody testing may reflect mom's transplacental antibody. Professional societies vary as to exact testing regimens in infants, but all advocate for PCR testing over antibody testing if you were to do a confirmatory test. Likewise, if a child remains positive, their PCR remains positive by 3 years of age, there are safe, effective, and tolerable all oral regimens with SVRs all very, very close to 100%. And these regimens are more or less curative. Now, if you'd like any more information about hepatitis C, you can refer to the CDC website that I mentioned here. And for therapy and monitoring guidelines, I think the best website is the AASLD website, which is hcdguidelines.org. Thank you very much.